much.
Thank you, Dr. Wang. That was a wonderful presentation. So we have next speakers, Professor Rajesh Sinha. I think he is not there. And we have Dr. Harbans Lal. I think he's also not there.
Sir, we have the video of Dr. Petrina, recorded video.
Okay.
Yes. So Dr. Petrina Tan will not be able to join us today, but she has kindly recorded a video of a talk on orbital trauma, looking into the future. So we can play the video now.
Dr. Wang. Okay. Okay, they are playing. Okay, that is fine.
Good evening all, I am Petrina and I am grateful for this opportunity to be involved in this All India Ophthalmic Symposium. So today my topic will be on orbital trauma looking into the future, and in particular I'll be focusing on orbital facial trauma for this talk. As an orbital facial surgeon, the goal when I'm faced with craniomaxillofacial trauma is to restore form and function of all structures of the face with complete healing and no complications. Maxillofacial fractures and reconstructions can be challenging with potential morbidity even in the best of hands. However, technology has complemented techniques in achieving more ideal outcomes in fracture repair than in the past. So new techniques include minimally invasive surgery with tissue preservation and minimal normal tissue disruption. Technology in the form of computer-assisted navigation surgery includes the use of DICOM data to virtually plan resections and reconstructions, customize implants, allow us precision in intraoperative localization and in implant placement. We have also made headway in orbital implants now with different kinds on the market. You have bioresorbable implants, standard and pre-band anatomical implants, and even patient-specific implants. I am very fortunate to have the support of a multidisciplinary team in the hospital when dealing with maxillofacial fractures. And by and large, we perform fracture reduction with computer-assisted navigation, much akin to GPS system we use to drive today. And these are the steps. First, we have a diagnosis based on the clinical findings and 3D imaging. There is preoperative planning, intraoperative navigation, and postoperative imaging and validation. The first step is to acquire CT images with cuts of 1 mm or less saved under an image guidance surgery IGS protocol. The next step is segmentation, where the cortical outline of the orbital-facial bones of the unaffected side is manually outlined and verified in the coronal, axial, and sagittal views for accuracy, and images are saved. The outline of the normal orbit and facial anatomy is then mirrored to the contralateral affected orbit and face, which will show the discrepancy between the normal outline and the disrupted bony outline. This data is then transferred to the navigation system for use operatively. Virtual computer-assisted planning and simulation of a facial and orbital reconstruction can also be performed on the basis of 3D datasets preoperatively in order to increase the predictability of the desired outcome and safety of the surgical procedure. The objective of surgical planning is to create a virtual model that matches the desired outcome of the surgery. The planning software that has been developed for this purpose also allows for threshold-based segmentation and or even atlas-based automatic segmentation during the process of creating such a virtual model. In the future, atlas-based automatic molding and deformation will more and more replace the procedure like mirroring, rotation, and manual deformation of virtual orbits, and will lead to more precise and especially quicker planning procedures. STL datasets or 3D bodies can be imported into planning software so that standard implants, anatomically preformed implants, and patient-specific implants can be virtually positioned in the patient dataset preoperatively, and the shape, size, and fit can be assessed. STL datasets can also be exported so that virtually generated models, reconstructions can be produced by 3D printing and allow patient-specific models to be created. And such models can be used to adapt and preoperatively bend patient-specific implants for reconstruction. At the start of surgery, the patient must be fused with the image data set displayed on the screen, and this process is known as referencing. The patient position must be registered and is accomplished by using a reference array or tracker. Depending on the navigation system used, a reference array or a tracker is fixed to the cranial vault or forehead respectively. And I routinely use the Brain Lab system, which depends on optical tracking systems rather than electromagnetic systems. So we use registration. We register using the bony landmarks, and once the technical requirements are met, the position of the pointer tip can be visualized in the dataset on the navigation screen. And this then allows us to determine our limits and safety zones of that section, as well as verify realignment of bony fragments. Intraoperative navigation also allows us to confirm that the implant is placed in the correct position with adequate support around. As the oculoplastic surgeon, I find this very useful in large orbital floor fractures or secondary fracture repairs, where the posterior ledge may not be easily visualized, and thus the pointer of the tip, represented by the crosshairs as seen in the last picture below, can help me. I'm going to deviate a little now from computer-assisted navigation surgery to mention about orbital implants and the changes we have seen in the past and what we can expect in the future. This is a paper published by our esteemed colleagues from NUH about their experience with the different orbital implants they have used in the last 10 years. Certainly not one size fits all, and different implants and dimensions work well for different fractures. These are some examples of permanent implants, titanium mesh, and technology has also allowed us to prefabricate patient-specific implants or even pre-bend prefabricated implants. This is another paper about pre-bending prefab implants using the angle of inferior medial orbital strut of the non-fractured orbit to achieve better outcomes. And another group who has used PSI and intraoperative navigation to achieve good results. We have also seen more bioresorbable implants in the market thus far. The first bioresorbable implant would be our autologous bone graft, but the disadvantages of that includes local donor bone morbidity and the lack of pliability. Bioresorbable implants have been used in reconstruction of orbital defects and various maxillofacial fractures with their advantages. So this is a patient who had fracture repair elsewhere but still had residual significant left inophthalmos. She was seen for her secondary fracture repair at NUH, and with the help of those at the Osteopo Company, we fabricated a patient model, an implant sample, and we made a patient-specific implant and placed it in the patient. So this is a post-op scan where you can see that the implants, which is represented by this hypodense area, is in good placement, and we have a very happy patient. There's another patient who was assaulted and sustained left orbital trauma, and preoperatively he had significant diplopia with limitation of adduction. The pre-op coronal fractures show a fracture of the orbital floor and the lateral and anterior wall of the maxillary sinus. He had restriction of the left eye in the up gaze, down, and adduction with significant diplopia on left gaze. So using navigational surgery, we perform fracture repair to localize the defect, the posterior ledge, as well as placing the implant. Postoperatively, this was his scans with the implant in good placement on the orbital floor and the return of his eye movements to normal. So along with minimally invasive techniques, newer implants and the use of intraoperative endoscopy, navigational surgery has been one of the greatest advances in orbital and facial reconstruction. So what does the future hold for us? Navigational surgery can be further improved upon having an easier setup, less invasive referencing, more accurate auto-segmentation eliminating the human factor, possible standard age, race, gender patient templates for patients with bilateral injuries. Intraoperative imaging in the form of mobile cone beam CT scans like over here will give low-dose radiation and provide real-time imaging and biofeedback while we are operating. And with that, I thank you. Good evening all, I am Petrina and I am grateful for this opportunity to be involved